Well, good morning, everyone. My name is Dr. Shelley Sekula Gibbs. It's a mouthful. That's why I have to have water, because you say that over and over, you lose all your saliva. I'm honored to be here this morning, and I know I saw all of you out there with me looking for a parking place. I congratulate you on finding one. I hope we all have our cars when we leave here, but I'm sure Dr. Alon will help us out with that, right? It is really, really a privilege for me to be here for the simple reason that this is a growing problem amongst my patients and amongst people around here, and I did not know what Lisa and Dr. Michael Alon were doing in order, or attempting to raise knowledge and raise awareness and bring people to the understanding of what you should do if you have this situation. I mean, a lot of doctors like myself could be out there practicing and not knowing what else is going on. So when Dr. Michael called me, I said, really? There's a foundation? I did not even know. And I wonder if how many of you knew about the foundation 2 years ago. Maybe it existed, I don't know. Did it exist, Lisa? I'm not sure where she went. But it's great that they're putting this effort together. It was around 2 years ago? 2010, excellent, good year. So it takes people with that kind of energy and that kind of passion to help us come out of the dark and into the light, and where more research will be done so we'll know what's going on for our children's sake as well as for our sake. So I want to just start off by telling you that there are certain things in dermatology that we see over and over and over, and that doesn't mean we do them right. Okay, that's the assumption, is that you go to the doctor, it's a common problem, and they're going to fix it. Well, unfortunately, in dermatology, like in I guess many other specialties, there are some things that we can't really cure, but we can make better. And acne is probably one of the first things that dermatologists probably enter the life of a person, of a woman, with whenever they hit teenage years and they start developing acne. And it is very common. I think the estimates are like 60% of Americans have acne at some point, and you just call it pimples, right? Something like that. Well, with PCOS patients, it gets a little bit different. They're usually not the patients that come in right when they're teenagers. They're often a little bit delayed. They're the women that I see coming in after many of the other teenagers have passed the acne time. And they'll come in often and say, you know, I just don't know. I had no acne when I was a teenager, and now all of a sudden I'm getting acne or pimples. And I'll start to think, okay, that's a trigger for me to start thinking maybe this person has a hormone abnormality. And we start wondering about that. So I start to ask them a few questions. I'll say, the first thing is, well, how are your menstrual periods? Are they regular, or are they getting longer in between? And are you skipping any? Have you tried to get pregnant and you couldn't? Does this run in your family? Situations like this, delayed acne, is it common for women to have trouble getting pregnant, that sort of thing? And lo and behold, on a lot of occasions, the women will say, yes, you know, I used to have very regular periods. I was on the birth control pill for a long time. Everything seemed to be going okay while I was on the birth control pill, but now all of a sudden I'm coming off of it because of one reason or another, or maybe I'm trying to get pregnant, and my face is breaking out, and I'm not getting pregnant. So I kind of divide patients right there. Is this patient somebody who's trying to conceive? Then I'm going to treat her very differently than if this patient says, no, I'm not trying to conceive. I just wanted to not be on the birth control pill for a long time. So at that point, I'll ask them, are you plucking your hair? Are you shaving? Do you feel like you're getting fuzzy all of a sudden? And sometimes they'll say yes. And if they do, that's another important factor that I start thinking about. Or I'll say something like, Do you feel like your body is getting hairier, not just your face? And sometimes they'll say yes, but they usually don't bring that up. For some reason, women don't like to talk about that, and I certainly understand. So I'll be kind of blunt, and I don't mean to be rude. So I'll ask, are you getting a little bit hairier on your body? I'll also ask things like, are you getting any changes in pigment on your neck or on your lip or under the arms? And then I'll say, have you had a weight change? And lo and behold, a lot of those patients will say, yes, it's getting harder to lose weight or maintain my weight. So that's another clue for me that we're going to order a hormone study on these patients versus all the other acne patients who come in and we don't order hormone studies on them because it's expensive. And sometimes insurance doesn't want to pay for it. I guess some of you may have faced that. So we have to be careful to document these things for the insurance companies so they will understand that this is a potential hormone imbalance, not just we're trying to throw money away. And so the hormone studies that I'll order usually for this are about 6 different hormones, including testosterone and cortisol and DHEA sulfate, 17-hydroxyprogesterone, prolactin, sex hormone binding globulin, and if the patient's really having weight trouble, sometimes we'll get insulin. These things don't always show us what we're looking for. Sometimes I'll have a clinically very classic apple-shaped woman who used to be pear-shaped and now she's more apple-shaped with acne, with facial hair, losing her scalp hair, but her hormones are all normal. And I don't know if Dr. Alon has seen that, but it can happen. Then you're going, oh, wow, now what do I do? Well, you don't give up. You don't give up. You still address the symptoms, and you address the capacity that you're just, or the possibility that you're just looking at that lab one moment out of a whole month of a woman's cycle, one moment that they drew the blood. We don't know if the hormones were going up, going down. We don't know. We just took it right at that one moment. So don't get frustrated and say, well, I don't have it, but I sure feel like I do, because sometimes the hormone tests are not correct. It's just a particular point in time that we looked, and it's like a roller coaster, and you know, sometimes the roller coaster is on the ground and sometimes it's up here, but it doesn't mean that it's not changing. So we have to be aware of that. And I will often try to engage the gynecologist in this situation, their internist, because it's a multi-system issue if I think that that woman has PCOS. Not only is her face having problems, and maybe she's losing her hair, but that weight can be causing other things like acanthosis nigricans. I don't know if y'all ever heard of that, but it's when a person starts getting velvety dark skin on their neck and under the arms. A person can also start developing something called HS. Now, it hasn't been linked clearly with PCOS, but HS, how many of you have heard about HS or hidradenitis suppurativa? Not too many, some. It is a condition that I think is related because it happens whenever you get, it's familial, and it's also something that seems to be only present after puberty, and it seems to burn out after you hit menopause, or for men as well, but men are much smaller of a percentage than women. HS are boils that occur, and they occur on the thighs, in the groin, up the buttock, under the breast, under the arm, and they're very painful, and they can just keep coming and coming, these boils, and they can make scars, and they can really be aggravating and very serious for the individual. So I ask about those because a lot of women will not bring those up, and they'll go, oh, I do, but they don't bring them. So volunteer these things to your doctor. Maybe the doctor looks real busy, but just go ahead and write down your list. I know doctors sometimes they dread seeing these lists, but it's important. Write down your symptoms so you don't forget to tell the doctor. I think it's very helpful to do that. So back to the woman who I was talking about who comes in my office and she has acne and she's got little facial hair and she's losing some hair. We've checked her hormones. Let's say her testosterone is a little high and she's not trying to conceive. Then what we can do is we can put her on an oral antibiotic if she wants, topical antibiotic if she wants to do that, a retinoid, which is like Retin A. But the crazy thing is, ladies, that insurance companies used to pay for Retin A or all these retinoids very easily. Now, if you're over 27, we have a hard time getting them to pay for it. Like you're not supposed to have acne, after we're 27. How silly is that? Anyway, that's another problem. But I don't see that changing anytime soon, but we have to just fight that. So we put them on a retinoid, which is like Retin A, maybe benzoyl peroxide, which you've all heard of, Proactive and all of that stuff, salicylic acid, sulfur, sulfa. All sorts of topicals are very useful in oral antibiotics. And sometimes we might even put them back on a birth control pill if that's something the person wants to try. Because remember, what the birth control pill does is it takes that cycle and flattens it out. But if the person really has abnormal hormones, we're going to do an ultrasound. If the DHEA sulfate is really high, we may wonder about the adrenal glands. We may get a CAT scan of the adrenal area, pelvic ultrasound. But sometimes that's just kind of no need to do that unless it's super high, because we know they're going to be abnormal, and it's like the cysts. They come and they go, they come and they go, and they may not be gigantic cysts, they may be little cysts. And so you might not even see them, but they're producing hormone. So some of these tests are done. I don't want you to feel like you were slighted if you didn't get these tests, because this may not be even helpful. They're done occasionally, and I guess Dr. Alon's going to talk about that more because that's his area. I often defer to the OB-GYN doctor at that point if I'm thinking that there might be some big cysts that might cause trouble. So, topical antibiotics, hair removal laser, also very good and very effective. On the scalp, trying to keep your hair, I like to use spironolactone, which is a diuretic. We've borrowed it from the internal medicine people. I guess we do that all the time, borrow. So it works well. It has to be, for a pretty long period of time. It has side effects. There's in spironolactone, some of you may have heard of that drug. It's not FDA approved for use in dermatology. It's borrowed from internal medicine. It's a diuretic for swelling, edema. But it works great because it blocks the hair from falling out. The testosterone can't get to the hair, so it blocks it from falling out. And it also blocks testosterone from affecting your oil glands and making the hair on your face grow. So it blocks facial hair and it keeps the hair on your head. So it's a pretty good drug for a lot of people. Rarely, but sometimes I will use finasteride, which men often use to shrink their prostates. But in women, we use it to block testosterone conversion from plain testosterone to dihydrotestosterone, which is the active part of the testosterone. Always during this time, I ask, any family history of breast cancer? Have you had breast cancer? Because we certainly don't want to use these medicines if somebody already has breast problems or ovary cancer, breast cancer, ovary cancer in them or in their family. So then talking about other things that can go, oh, I gotta hit this one too. Rogaine, I like to use men's Rogaine, not women. Again, the FDA says women, forget that. Use the men's, it's stronger. 5%, in my opinion, is a better choice if you're gonna use Rogaine for hair loss. And so then, if the person has got the acanthosis nigricans or they've got a lot of skin tags, I ask them, have you had any colon cancer in your family? Because if so, then I want you to go and have, talk to the GI doctor, talk to your primary care doctor to make sure you don't have a need for a colonoscopy. Because sometimes if you're making a lot of polyps and changes on the outside, it could mean that you also could be making changes on the inside of your colon. It's not hard and fast, it's not proven, but these are just indicators. So what do you do about the velvety skin and the skin tags? Well, we can trim the skin tags, but we have to get the weight down, because as the skin is rubbing skin, that's when the HS can develop, that's when the boils can develop, and you know, it's a vicious cycle. So bringing down the weight, and that's the hardest thing in the world, isn't it? We can take a pill a lot easier than we can just turn off our jaws. And I think that other guests, other speakers are going to address that probably better than I can, but I really think that controlling sugar is probably one of the hardest things, but one of the most important things we can do. Just bring down that sugar, because I think it's almost addicting to people. So I suggest to my patients, watch the sugar, try to bring it down. Some people go so dramatic as they just try to eliminate everything white in their diet, you know, and that may have a place for you to get started from. Just say, make it easy. If it's white in color, I'm not going to have it. That would be no bluebell, but anyway. So those are some things that I look for. That's how I approach PCOS type patients whenever they come in my office. I do prescribe metformin on occasion, but I like to really let that be handled more from the internal medicine doctors and the other specialists who might want to do that, because I'm no expert at using metformin. I enjoy taking care of PCOS patients, and I've seen wonderful results where a patient will go from having hardly any cycles, hardly any menses throughout the year, losing some weight. We do the hair removal laser. We stop the hair loss. We bring it, you know, with the spironolactone, it starts to come back. And lo and behold, all of a sudden, they start to become more normal again. And it's really, it does happen. I've seen it over and over. So there is hope. I want you to definitely feel like there is hope. And if you took the blood levels, you could watch them start to come back to normal. So I'm going to stop right here, and I'm going to open up to questions, because usually at situations, events like this where there are lots of patient or people who in the audience who might or might not have this, or you know somebody who may or may not have this and you're interested, I always find that the questions that they have are probably more informative than anything I can say, because they're real. So I want to thank you again for inviting me today. It was a privilege to be here and be with you and be part of Lisa and Michael Alon's effort. It's great that they take this seriously and that you take it seriously, and that we will work together to try and resolve it. Thank you very much.
Did you say that if you have a history of breast cancer in the family, that you should not take spironolactone? And also, did you mention Fenestra? Is that the same?
What I said, yes, that is what I said. This is, again, what I do, because there are no guidelines on this. You know, this is not even approved for use in hair loss or acne. But what I do is I say, is it a first-degree relative? So if their mother or even their grandmother had it young, had breast cancer young, especially under the age of like 50, 55, I become a little more alarmed about that. And ovarian cancer, I throw that in there too. I'll tell them, you know, this is probably, those two drugs are probably not the best for you. There's not a lot of data on it, but there is data way back in the old days, like 40, 50 years ago, when spironolactone was being first studied, that showed that there were increased tumors in laboratory rats, and breast tumors, I should be specific, increased breast tumors in laboratory rats. Now, that has never, to my knowledge, translated to any kind of document that says there's increased breast cancer in women. But it is there for the animals, and so I think it's always, we should be careful. You know, we should be careful not to gloss over those kinds of warnings. And if a person has it in their family at an early age, I would say under 55 or under 50, I would just say be very careful, be very careful. And I'll also start them on getting mammograms earlier if they have that family history. Let's say they have a great aunt who had breast cancer under the age of 50. I'll start them on having mammograms instead of at 50, 35, something like that. And we'll do it more often. I guess that's a little paranoia, but, better to be safe than sorry. Any other questions? Yes? Sure. The question is there anything over the counter that can be useful, sorry about that, useful for acne? And yes, there are lots of things over the counter. As I already said, benzoyl peroxide, it's a tried and true. It's very irritating. A lot of women don't like it. Certainly you don't want to get it on your fabrics because it'll bleach. Don't want to get it on your carpet or your sheets. But benzoyl peroxide is effective in some cases, washes and gels and little things that you can pat on. Over-the-counter salicylic acid is very good. A lot of products with the salicylic acid in the wash and in the creams and gels. Also, the sulfur. There's adult Acnomel. It's been around a long time. It has a little bit of a funny smell, but it's not expensive, and you just put it on the pimple, and often by the next morning, it's dried out. Sulfur is very effective, and there are a lot of different products that have sulfur. Now, sulfa requires a prescription. And you can become allergic to sulfa, but you can't be allergic to sulfur unless you're like President George Bush and he said he couldn't stand broccoli. But that's the sulfur in the broccoli that makes it smell like that. Though I think a lot of kids say they're allergic to broccoli and cauliflower, but not so. So anyway, sulfur is in our hair. So if you smell a piece of hair that's burning, it smells kind of funky, that's the sulfur that you're smelling in there. So any other questions? That's a good question. Do you recommend combinations of over-the-counter or one at a time? I'm kind of a one-at-a-time person initially, because that way if you have a problem, you know to what you reacted. And then you can add things, and I think that that's a good way to go. Plus, alternating. You don't have to do the same thing every day. And also remember that around your cycle, quite frequently, that's when your acne is going to flare. Not on everybody, but many. So you may want to really hit it a lot harder the week before your menstrual cycle. But then, unfortunately, if you can't tell when you're going to have a menstrual cycle, it's, it's a little harder to do that. Any other questions? Yes, ma'am. You're going to have to speak up. Okay. Okay. The question is there a dose of spironolactone that I like for different conditions, and is there a dose that I won't go over? I generally start at 25 milligrams, and it comes in 25s and 100s. Don't get those mixed up. 25 milligrams once a day for a week, and this is my routine. We get into routines. It doesn't mean it's right, but this is easy for my staff and for me to remember. So 25 milligrams once a day for a week, and then I go to 2 times a day for a week, and then I go to 3 times a day for a week, and then I finally build up to 4 times a day for a week. And then they come back and see me, and we draw potassium. And we usually draw some blood before we start to get a baseline potassium, and then we draw again. Now, a lot of women do very well at 100 milligrams, and then we can convert that from 4 pills to 100 milligram. But don't be like one of my patients. So as soon as I converted it, she forgot, and she was taking 400s every day. It was a very good experiment. She did fine. But I almost had the heart attack. So I aged a little bit when she called, and she said, "I'm out of my medicine." I said, "How can you be out of your medicine? You know, we just gave you some a week ago." Anyway, she was taking 4 at a time. It didn't really hurt her, so I was relieved, but they had to peel me off the floor. So that is probably a test to show you it's not all that powerful. If a person responds well to their acne, it's often at the 25 to 50 range for acne. But if we're trying to knock out facial hair and trying to bring back scalp hair, I often see we need 100 and sometimes 150 and sometimes 200. It also goes kind of by our size. You know, I'm a big girl, I probably could handle more versus some tiny person who's going to probably not need as much. It's not a weight-based drug, but I kind of see that in my practice. Does anybody here have any comments about that, about spironolactone, a magic dose that's worked for you? That's just how I do it. I know not everybody does it that way. Any other questions? Yes? You can take it all at once, but I start it broken up like I do, stair-stepping, because when you're on spironolactone, being a diuretic, you lose fluid in your urine, and so when you sit down and then you stand up quickly, sometimes you can feel very weak and like you're going to pass out for a minute or two. And so I find that if I stair-step it up, and then after that, you can switch over to one pill, something, or take both of them at the same time, their body seems to have a little easier time of adjusting to that change in blood pressure when you go from sitting to standing. No, I don't tell them. I tell them once in the morning is fine. And the reason I push them to the morning is because if you take a diuretic at bedtime, you tend to have to get up a lot. So that's no fun. Any other questions? You may be done. Or I may need to move along. Well, thank you very, oh, we have one more. Okay. Okay, that's a good question. What type of makeup or foundation? I generally say oil-free. Non-comedogenic is probably not good enough because I've seen some makeups call themselves non-comedogenic and they still have oil in them. I'm like, non-comedogenic for whom? You know, I don't know. But I just say oil-free, and you can decide which one you like. Some people like powders, some people like creams, you know. And I do recommend, I need to throw this in, and a sunscreen every morning that has zinc oxide or titanium dioxide, a physical block in it. Because if you're going to be using a retinoid at night, and by the way, you can put it on your arms and your shoulders, and you can put it on your chest to try and minimize the sun damage that we get in Houston, and then use sunscreen in the morning. So that's a good way to moisturize because the retinoid dried you out overnight typically. So thank you again. I appreciate it. Oh, one more? Oh, okay. Go ahead. She asked about if a person has severe HS, could they also be somebody who has PCOS? And I'd say it's possible because a lot of the HS patients also have symptoms of PCOS, like the weight gain, the irregular menstrual cycles. I think sometimes we forget. We get so tied up in the boils and the sores and the pain that we forget, hey, there could be a hormone imbalance underneath all of this. And so I think that needs to be studied more. So thank you again. Have a wonderful day.